You're watching Cetome TV. Knowledge is power.
I wanted to briefly talk about some of the new drugs. This is amazing classes of new drugs.
Okay.
So in combination with androgen deprivation therapy, which is a typical approach, there's a class of drugs called androgen receptor antagonists.
Okay.
And so what they do is they antagonize the androgen receptor.
And they make it absorb, they make it go to work. Is that what they do?
No, they do the opposite.
Oh.
Remember, the androgen receptor binds its ligand and then signals.
Yeah. But I thought
we
it was
don't want
not
it to
able
do
to.
that.
Oh, we don't want it to do
No.
that.
And when you have the ARV7, then what happens is it does it by itself without the testosterone or the androgen.
I see.
So what we're doing is we're preventing that receptor from working properly with these drugs. And that's why they're called antagonists.
Okay.
They antagonize the receptor.
Okay.
So there's 3 FDA approved ones for prostate cancer right now. They're all approved for metastatic hormone sensitive prostate cancer.
Okay. Which means?
That it's still responding to hormones.
Okay.
Or anti-hormone therapy. Still responding to ADT.
Okay.
Somewhat.
All right.
But it's metastatic.
And how would they be telling that it's still responding? Typically in standard
the PSA
care?
typically goes down. Yeah.
Okay. Thank you.
Or remains stable.
Okay.
But at diagnosis, you have a lot of tumors all over your body. So you're stage 4 right off the bat. So there's 3 of them approved. One of them, the oldest one, is called abiraterone. It works really well. There's a trial called the Latitude trial.
Okay.
And it showed that in these prostate cancer patients, there was a overall survival of 53.3 months versus 36 months just for ADT alone.
And these are advanced cases, or this is?
This is all stage 4, metastatic hormone sensitive prostate cancer.
Okay.
This is what we're talking about, this group of drugs.
It is what you are talking about. I'm just not as knowledgeable as you, so you have to bear with me. Okay, go ahead.
So also for metastatic hormone sensitive prostate cancer, there's another drug called enzalutamide. That was done in the ARCHES trial.
How current is this?
It's relatively current.
Okay.
Now, this was a group of patients that was very sick. 18% of these patients had already had like 6 cycles of docetaxel and were still very, very sick and not doing very well. So, they gave them this drug. In this trial, the progression-free survival was not reached for the people taking enzalutamide plus the ADT. And for the ADT alone, it was 19.4 months. And the overall survival was, I think, I can't quite remember. It was, I don't have the time for it, but it was like 20% more patients on this trial taking enzalutamide had a great response.
Okay.
Compared to only 63%.
Oh, okay. So with that first one that you mentioned before I interrupted you with my question, people got an extra 2 years or so, and they were already stage 4, quite advanced. And this one, there's also quite a significant
huge difference,
improvement.
Yes.
Wow.
Much better than abiraterone.
Wow.
And then there's apalutamide,
okay.
which was showed in the Titan 3 trial. So in this particular one, once again, this is metastatic hormone sensitive prostate cancer.
Okay.
These are all FDA approved drugs. So they are used in regular practice. Whether they're at your hospital or not now is another issue. There was a 52% reduction in death or progression with this drug combined with ADT.
Okay.
And progression-free survival for this trial, because it's not over, I believe was not reached in the combination group and was 22.1 months for the androgen deprivation alone.
Okay. All right. So they're still waiting, actually.
Yeah.
They need more time.
Most of these trials are, yeah. So
okay.
These are.
That's how new they are.
Yes, they're very new drugs, yeah.
Okay. But years of life being added for people.
Right. Okay. So one of the common things that happens in prostate cancer is patients stop responding to ADT. And whether it's because of the two prognostic features I discussed earlier, whether it's that receptor that doesn't need ligand binding to signal, there's many different factors there. But eventually, most prostate cancer patients will become what they call castration resistant. And so by then, there's not really a lot of treatments apart from chemotherapy, which is not very effective there.
But as you're saying, and I think this is important to note, or at least clarify, that data may simply be because it's not standard to use the genetic testing beforehand to make sure you've appropriately stratified people.
Yes.
They're not necessarily
stratified.
They're not stratified.
Yeah.
They're not gay. So that statistic may not be accurate when cancer is treated in a precision oncology way.
Of course.
Right.
This is standard treatment.
Okay.
All of these trials
want to say that
are
because it's important
specific.
to understand that the huge impact that one piece, like genetic testing, can have.
Definitely. Yeah. All of these are specific. All of the data is specific to standard treatment.
Okay.
All clinical trials compare their data to standard treatment.
So that, and what we see is the results from precision oncology are always well and beyond standard care. So that's even better news for you with these new FDA approved treatments. Wow.
So the final drug I want to talk about is showing evidence for response in castration-resistant prostate cancer. So this is a huge gain in treatment. So the drug is called darolutamide. It's once again an AR antagonist, but it is the one that we believe is going to be the best drug.
Okay.
So it was originally approved by the FDA in what was called the Aronson's trial. And it showed a huge benefit for hormone-sensitive prostate cancer patients when combined with ADT and docetaxel. So they used all three drugs there. And huge benefit. And there's two trials right now, one called the ARADES and the ARA4. And they're actually looking at metastatic castrate-resistant prostate cancer. So these are patients that are resistant to ADT therapy.
In case you're wanting to check this out at home, ARADES is ARADES, and ARA4 is ARAFOR.
Yes, thanks.
You're welcome.
So this is a better drug than the other AR antagonists. It's one of the best drugs. It's got increased efficacy, so it works better at a lower dose.
Oh, that's good.
Importantly, it works on those androgen receptor mutants. So the negative prognostic features, the ARV7 and the ARV9. There's many different mutations that you can have in the androgen receptor. Those are just two that we discussed. But this drug works on those. So it's one of the only drugs that works on those.
Okay, that's
so
exciting.
It has a different mechanism for binding the receptor. So if the ligand binding domain is missing from the receptor, this drug will still work.
Wow.
Whereas the other three won't. And that's probably why it works on castration-resistant prostate cancer as well as hormone sensitive.
Right. And that's darolutamide.
Darolutamide, yeah.
Okay.
Now, one of the big problems with any AR agonist and hormone therapy is it can cause a lot of problems, what we call CNS activity. And so this can be strokes, strokes and seizures and stuff can happen from this, So
from this new drug you're talking about?
No.
Oh, sorry.
I'm saying from prostate cancer treatment, ADT.
Okay. Okay, from the standard treatment.
From the standard treatment.
Okay. This is where my lack of knowledge of this particular type of cancer is really showing.
It's a very complicated thing.
Okay.
Don't worry about that. This is so new. So
okay, but the androgen deprivation therapy, which is a common approach, has these nasty side effects to the central nervous system.
Yes. When combined, especially with these AR antagonists.
Okay. All right. So what are we going to do about that?
Well, most people just try to manage them with steroids. You don't really have a choice. It's either the disease progresses and you die quicker, or you try to deal with these side effects, and they can be seizures and strokes and things like that. So they're nasty side effects.
Yeah.
so you have to be well monitored.
Okay.
So
And
with
so-
darolutamide, it is a unique drug in the sense that it doesn't cross the blood-brain barrier. And that's what makes it so special, is because of that, it has totally reduced side effects compared to the other AR antagonists. And you don't have to worry about these seizures and things
Seriously?
like that. Yes, this is a new drug. This is going to change all of this. So the AR antagonists have been around for a while, but this is the latest AR antagonist. Number one, doesn't have the side effects, the dangerous side effects. Number two, works better. Number three, works on androgen receptor mutants that the other ones don't work on. And number four, the most important thing is it also seems to work on castration-resistant prostate cancer.
Wow.
So it is the new drug.
The golden
New
child.
golden child, yes.
Sure. Just to have so many more benefits and so much less chance of those side effects.
Yes.
Wow.
Yes.
And longer survival.
Yes.
That's all good.
Yes.
So that's.
But we don't know the survival yet. The trials,
It's
the
in a
trials are
trial.
still out. Two
Okay.
trials.
But it's already showing good results.
Yes.
And so that's the ARIDES or the ARA4 trials.
No, those are for metastatic castration resistant.
Okay.
And the Arisons was for hormone sensitive.
Okay. All right. So let's say my brother has just been diagnosed with prostate cancer. He's got all the markers that would be relevant. Would he be able at this point to ask his doctor for this darolutamide as part of his treatment? Or is
What
it
does he
still...
have?
Well, I don't know. I'm assuming he's got all the stuff.
We would have to look at his case.
Okay. What I'm trying to... Right. So we need the genetic testing. We're back to that. You have to
Well,
know.
we'd need to know what his staging is. We'd need to know if he's castration resistant. We'd need to know if he has resistance mutations. As you say, looking at the...
So those are some important pieces of information.
Yeah, exactly.
Once you have that information, you can better assess which treatment would be best for someone.
Exactly.
Obviously.
We have to look at everything.
Right. That makes
The
good
full
sense.
medical records
Okay.
review.
I guess what I was really trying to say is, given that this is such a new treatment and so incredibly beneficial, is that something that is accessible to?
Yes.
Okay. It is available.
It's an FDA approved.
Okay. Awesome. Good news. Because, why wouldn't we? Yeah.
Very much so.
All right. What else would you like us to know, if anything?
I think that's
prostate?
about it.
That's pretty much it?
Yeah. We've gone a bit over.
Okay, we have. We're starting to do that, aren't we? But this is really good information, Alex. Thank you.
Yeah, there's a lot of information here, and I apologize if a little bit was a little complicated.
Well, for me, but
there's
not
a lot of
necessarily
stuff
for
there.
all the folks watching at home.
And to explain it in such a short period of time, we probably needed 2 sessions for this.
Well, let's remember that for next time.
Okay.
Or we can certainly do some more a little bit later on this particular topic. But this is excellent information and really inspiring.
It should be. For anyone with prostate cancer, be inspired.
There's a lot you can do.
Be inspired. There's so much going on right now. And spend the money on the genetic testing. Don't just do wait and see.
Yeah.
Definitely spend the money on genetic testing.
That's the thing. And then you just have the details about what's happening in your body, and it makes it so much easier to access all of these treatments that are going to be so much better than standard care for you, probably.
Yes.
Thank you for watching Ketome TV. Subscribe below and stay informed.